Hello my dear curious and studious students of surgery. Myself Dr. Mahesh Chaudhary. I am warm welcoming you in my surgery lecture series. This surgery lecture series contains entire surgery with anesthesia, with radiology, with orthopedic. So stay tuned with us. Let's start our surgery lecture series. Welcome dear students in my surgery lecture number 51, that is the acute pyelonephritis and tuberculosis of kidney. In this lecture we learn acute pyelonephritis, chronic pyelonephritis, perinephric abscess, pyo-nephrosis and the tuberculosis of the kidney. Now start with the acute pyelonephritis. The term pyelonephritis means inflammation of the kidney and renal pelvis. The term pyelitis means inflammation of the renal pelvis only, but it is doubtful whether such condition can exist alone or not. Now the pathogenesis of the acute pyelonephritis. In this condition, bacteria reach the kidney either through the bloodstream or by the ascending infection. Now first, ascending infection. In majority of cases, acute pyelonephritis develops from infection in the bladder through the mechanism of the vesicoureteral reflux. Second is the hematogenous infection. Pyogenic cocci are more often seen in hematogenous infections through E. coli is the commonest infection organism in all cases of pyelonephritis. Dear students, here is a good image on your screen you are watching. That is the typical picture of the acute pyelonephritis, how it looks like. Now the second image is animation showing the acute pyelonephritis, bacterial infections of upper urinary tract and lower urinary tract infection. It is the retrograde infection through the vesical urethral reflux. Systemic symptoms like fever, flank pain, treatment, antibiotics. This image showing. This is the CT image showing the pyelonephritis, acute pyelonephritis bilaterally. Now the clinical features of the pyelonephritis. As mentioned earlier, acute pyelonephritis is more common in the females, particularly during the pregnancy and soon after marriage, which is popularly known as the honeymoon pyelitis. Peculiarity in this condition affects right side more often than the left side, but it is maybe bilateral. Now the symptoms: constant ache means pain over one or both kidneys is the most frequent complaint. This is mainly cause distension of the renal capsule due to edema. Second is increased frequency of micturation, urgency, nocturia and burning sensation on urination are the complaints due to cystitis, which often accompanied with. Third is the rigor along with high temperature is quite common. Now the investigations in the pyelonephritis is to be done, that is the blood examination, which is routine, CBC, leukocytosis and erythrocytosis. Then urine examination is usually scanty and highly concentrated. It is usually cloudy. Protein content becomes high. Urine contains large amount of pus and bacteria. Bacteriological examination of the urine, that is the midstream specimen, should be collected in the sterile test tube. Extra-straight X-ray of the abdomen, radionuclide imaging, the kidney with the gallium-67 may be used to localize the site of the infection, that is 85% accuracy has been claimed. Now the complications: if diagnosis is delayed and treatment is inadequate, the condition may turn into the chronic. The complications are renal insufficiency, renal ischemia and hypertension. In fulminating pyelonephritis, bacteremia or septicemia may be present. First, general measures: pain should be relieved with antispasmodics. Bed rest is highly important as drink large quantities of fluid, at least 3 liters per day. Vesical irritability. Second, B specific treatment: antibiotics should be started immediately. Tetracyclines, ampicillin, cotrimazole, polymyxin, B, gentamicin, kanamycin and amoxicillin is to be the drug of choice in such condition to treat the pyelonephritis. Once the culture and sensitivity reports are in hand, the proper antibiotic should be started in high dose for at least 10 days till the urine is rendered sterile and clear. Third is the failure of the response. If no clinical improvements occurs in 2 to 3 days after offering above treatment, excited urograms should be advised. Detect any obstruction or vesicoureteral reflux. Now the next point is Pyo-Nephrosis. Pyo-Nephrosis means dilatation of the pelvis and calis, which are filled with the thick creamy pus. Though the nomenclature is restricted to the pelvis and calyces, yet there is always great destruction of the renal parenchyma. Now the etiology and pathology. Pathogenesis: this condition may develop from infection of a hydronephrosis, from acute pyelonephritis, or as a complication of the renal calculus, which is known as the calculus pyonephrosis. This is the ultrasound image showing the pyonephrosis, dilated calyces, parenchyma is thin. This is the transected picture of the pyonephrosis. Now the clinical features of pyonephrosis are First symptoms, patient may present as a swelling in the loin, high fever and prodromal symptoms may be associated with symptoms of cystitis and bladder. Irritation, bladder irritation, that is the increased frequency, urgency and nocturia may be present. Physical signs, pyrexia and anemia are noticed. Renal tenderness is always elicited. Now the investigations in the Pyo-Nephrosis are straight X-ray, extraordinary urography, extraordinary of dye may be delayed. Cystoscopy reveals cystitis and purulent reflux through ureteric orifice. Treatment. The role of surgery is extremely significant in obstructed cases of Pyo-Nephrosis. This should be treated immediately. Percutaneous nephrostomy should be performed under the cover of antibiotic. The stone should be removed through nephrostomy. When the condition is bilateral or the only remaining kidney has been Pyo-Nephrosis, permanent nephrostomy is the best treatment. A few neurosurgeons may consider ileal conduit as a permanent drainage. Now, the next point of this lecture is tuberculosis of the kidney. Before going to the tuberculosis of the kidney, there is a one condition also there, that is the perinephric abscess. Perinephric abscess may be primary or secondary. Primary form is mostly hematogenous. The infection is carried from distant foci, and secondary form occurs as the infection travels from the neighboring organs. Clinical features are is equal to same as a pyelonephritis. Investigation are also same. Medical treatment is also the same. But in the surgical treatment, when the flank abscess is present, surgical drainage through the flank should be performed. Now the tuberculosis of the kidney. Renal tuberculosis is never a primary condition. Tubercle bacilli invade kidney through blood from a distant focus, either lungs, lymph nodes or bones. The infection organism is Microbacterium tuberculosis. However, if enough bacteria of sufficient virulence become lodged in the kidney, a clinical infection is established. Kidney tuberculosis is almost always unilateral at the commencement and may remain so for a remarkably long time. Eventually, however, the other kidney may become involved. Tuberculosis of kidney progresses slowly and it may take 15 to 20 years to destroy a kidney. In a patient having good resistance, the real clinical criterion of acute renal tuberculosis is the presence of pus and red cells in the urine along with tubercle bacilli, and not just the presence of tubercle bacilli alone. This should be remembered. Now, this is the image on your screen. Dear students, you can see there is a typical picture of the tuberculosis of the kidney. This is the CT image showing the tuberculous kidney. This is another image showing the tuberculous kidney. Now the pathology. First, macroscopically, the primary renal lesion usually involves upper or lower pole. The pathological process is first noticed in one of the positions, first at the base of the pyramid or at the apex of the papilla. In early stage, small lesion may be observed at the base of the pyramid or in one of the papillae. Soft yellowish cheesy material may be seen at the site of destruction. In later stage, there is a progressive destruction of renal tissue with cavity formation. The kidney becomes enlarged and or its surface distinct tubercle or larger bosses denoting cavity formation from within may be detected. In the final stage, the kidney becomes functionless. Mass of the tuberculosis tissue. The kidney may be enlarged due to Pyo-Nephrosis or may be shrunken and atrophic. Now the ureter. Tuberculosis of the ureter is secondary to tuberculosis of the kidney, obviously. The infection passes down in the submucous coat of the ureter in which definite tubercle may be seen. This is followed by the ulceration of the mucosa. The muscular coat and serous coat becomes infiltrated and thickened. It is the upper lower thirds of the ureter which are more often affected than the middle third. Thus, the ureter is gradually covered into the thick, rigid and dilated tube. Only occasional scar formation may give rise to localized structure of the ureter. Now, the clinical features. Renal tuberculosis is a disease of early adult life, being commonest between the ages of 15 and 14 years. Males are affected twice as compared to females. Symptoms. No classic symptoms of renal tuberculosis. Generalized malaise, fatigue, continuous loss of weight, low grade evening rise of temperature, night sweats are some of the non-specific complaints. Renal pain is often absent. Hematuria, vesical involvement. The early symptoms of renal tuberculosis arise from the secondary vesical involvement. Now the investigations in the tuberculosis of the kidney and ureter. Blood examination may show the lymphocytosis. Anemia may be detected in advanced case. ESR is always raised. Tuberculin test through insignificant when positive, but it is highly significant when negative as it most excludes tuberculosis. Third is the urine examination. Culture for tubercle bacilli from urine are positive in more than 90% of cases. Fourth is the X-ray examination. Straight X-ray may show calcification of the healing foci, excretory urograms, irregular density in the nephrogram, loss or dysfunction of one or more calyces, spasm or edema may obliterate calyceal neck, hydrocalyx, mouth-eaten appearance of involved calyces. All these are the comparatively early changes. Obliteration of one or more calyces, abscess cavities that connect with calyces, space occupying lesion displacing calyces and pelvis, single or multiple unilateral strictures, shortening and dilatation of ureter, absence of functions of the kidney, loss of natural curves of the ureter which becomes straighter, shorter and dilated, and spasm and flattening of the urinary bladder due to ulceration. Contralateral ureter may become dilated due to secretory obstruction of the ureter as its intramural course. Then the retrograde urogram is usually not required but may be necessary if excretory urograms fail to reveal pathology. And next is the chest film should always be performed to exclude tuberculosis of the lungs. All these are may be seen on the X-ray examinations. Now next investigation is the cystoscopy. This will clearly demonstrate the extent of disease in the urinary bladder. Due to cicatrization of the ulcers, there is a severe contracture of the bladder in which the capacity of the bladder steadily diminishes. Now the treatment. It must be remembered that the renal tuberculosis is a part of generalized disease, so general treatment of tuberculosis should be the prime treatment. Various combination of the anti-tubercular drugs should be given. Previously injections streptomycin, isoniazid and PAS were given for at least 1.5 years. Rifampicin 600 mg, isoniazid 300 mg, pyrazinamide 1 gram and vitamin C 1 gram daily for 2 months followed by the rifampicin 900 mg. Pyrazinamide 1.5 gram and vitamin C 1 gram twice a week for 4 months is quietly effective. Ethambutol 800 mg may be given in combination with rifampicin and isoniazid. Good protein rich diet and vitamin supplementation should be given. It is mandatory because there is a weight loss. Second is the surgical treatment. Some tuberculosis lesions of kidney are surrounded by the fibrous tissue so that the anti-tubercular agent cannot reach the lesion in sufficient concentration to kill the organism. These cases requires operative treatment. The optimum time for operative treatment is after 6 to 12 weeks of anti-tubercular treatment, which has failed to bring about certain improvement of the condition. Second is the nephrectomy. If after 3 months of medical treatment, the culture of the urine is still positive and there is a gross involvement of the affected kidney radiologically, nephrectomy should be considered. Nephroureterectomy. When the bladder is extremely contracted, which is known as the systolic bladder, it is better to increase the capacity of the bladder by performing ileocystoplasty, that is the handless operation, in which 15 cm of terminal ileum is isolated and is inside at the antimesenteric border and is sutured to the remaining portion of the bladder. After excising the scar tissue from the dome of the bladder, continuity of the ileum is restored by end-to-end suturing after isolating the 15 cm of loop of the ileum. Dear students, here is the end of our lecture number 51, that is the acute pyelonephritis and tuberculosis of the kidney. Thank you.